Robot algorithm.
2 words.
Yes. Yep. 2 more words. Artificial intelligence will be your PCP. It's more than 2 words.
But to your point, if I'm looking at retatrutide and I am trying to study it versus a current GLP-1, I guess I would want to pick an equivalency. But if I'm a company that has shareholders to reward, then maybe I'm motivated to pick the dose that makes my results seem the best. So if I'm wanting to prove that the existing compound I have, let's say it's tirzepatide, is just as good or better, I'm going to use the mid-range dose of retatrutide. If I'm working for whatever company has scooped up retatrutide, then maybe I'm just going to use 5 mg tirzepatide and pit that against my max dose retatrutide and say, look how much better this is, to create some distortion.
Yeah. So basically what they did in the SURPASS-2 trial, if you look at that up on the screen, they studied 1 mg semaglutide versus not 1 mg tirzepatide, which, by the way, you can give to patients. How do you give a dose if you can't count clicks? Because with Ozempic, you can count clicks. With Wegovy and Mounjaro, you cannot count clicks. So there's one secret biohack of how you can do that. And how they've likely done that, like very possibly done that in a lot of clinical trials as well, is use a dose that is not supposed to be used. But yeah, anyway, they used the 1 mg semaglutide and 5, 10, and 15 tirzepatide, which makes tirzepatide look pretty good there. So again, if you just change the units, multiply by 100, compare 100 mgs of trenbolone to 500 mgs, 1,000 mgs, and 1,500 mgs of testosterone. Maybe not the best example. Maybe you think about 10 mgs trenbolone versus 50 mgs test per week, 100 mgs test per week, 150 mgs test per week. Now I'm talking more clinical doses and not bodybuilder doses.
Yeah, I mean, if you look at milligrams, some people out there will look at a milligram dose on a drug and think, wow, that's a lot. It's like, oh, you've got 1,000 milligrams of Tylenol or 20 milligrams of oxycodone. Like, of course, the oxycodone is much more potent as a pain-relieving agent, even though the milligram dose is substantially lower. And they're not in the same class by any means other than being analgesics. They have very different mechanism. But the milligram that you're looking at doesn't always represent, just because something is a few milligrams doesn't mean that it is necessarily weak.
Yeah.
And this is a perfect example of that.
Yeah. So it's interesting that these triple agonists that people are calling synergistic or dual agonists, dual incretin, like tirzepatide, you would think if it has 2 mechanisms of action, kind of attacking the insulin resistance from both fronts, if you will, that it will have better efficacy. But it's also very possible, as we've mentioned in the past, that it has more side effects. And I'm not trying to manifest this into existence, but the synergistic growth hormone secretion, especially from a triple agonist where you have high glucagon as well, high glucagon agonism, I am very concerned that high doses of that will lead to extremely fast tumor growth. Because I would love to see a growth hormone area under the curve compare a triple agonist versus doses of omnitrope, which is recombinant human growth hormone. I bet that the high doses of triple agonists that are going to be approved at some point are equal to a pretty hefty dose of HGH, which we know leads to lots of tumor growth and cancer risk. And again, I'm just putting that out there so that clip is there for somebody to pull up in 5 or 10 years when we're like, oh, we found out that all these obesity medications also cause cancer, which other obesity medications and diabetes medications have in the past. So hopefully it doesn't manifest it into existence.
Yeah, but it is a real theoretical concern. I mean, we have seen patients who have very significantly increased IGF-1, people reporting like unintentional benefits, like, oh, like my skin or my hair, these things are getting better being on this medication. Very similar to the positive side effects of growth hormone therapy before it was sort of shut down, people overusing it for cosmetic purposes. So if you're taking something like 2.4 mg semaglutide and now you're giving people 3 times that amount.
People would never overuse this for cosmetic purposes.
Right. I think it is a significant concern. And to your point, the glucagon, that's also going to be a growth hormone secretagogue. You have all these sort of GHRPs that aren't GHRPs, and the same people who are shouting these medications have no signal towards any increased cancer risk. There is no way these can increase cancer risk. There's people saying that. They probably hold the same viewpoint that people should not take growth hormone because of the cancer risk. I just think they're unaware or they're ignoring the data and the mechanisms we know are there.
Robot algorithm.
2 words.
Yes. Yep. 2 more words. Artificial intelligence will be your PCP. It's more than 2 words.
We should make that one a real.
Imagine your AI PCP arguing with your AI. By the way, the old model of the AI, let's make that clear. The old model of the AI is no longer a PCP and is now working for the insurance company, which is denying the prior authorization attempt of your AI PCP.
Oh, so it's like it's battle bots, but with chat GPTs.
Yes. Elon Musk's artificial intelligence is your primary care provider, but the insurance company have bought the old model of Jeff Bezos that learned from the Amazon primary care thing. And they have now retired and are working for the insurance companies.
Yeah, it's going to be an interesting future. I think one component that could be interesting is the AI as your primary care or even as a health optimization specialist for the basics, right? So you put on your Google glasses or whatever, some sort of AI. It's like, oh, you're having these symptoms. Like, let's see what a couple days in your life looks like. And then it sees that you are just downing processed food, spending 6-8 hours a day on your phone, you're sleeping 4 hours a night. And then, you go back to your AI GP and it's like, oh yeah, I wore the Google glasses. What did my test results say? Of course, it'll have the blood work and all the medical knowledge in the world there. And it'll say, well, you need to eat less and move more. And people are like,
less.
The AI is broken. It's not working. That would be some people's literal response. But
AI does not know about metabolic damage and adrenal fatigue.
It would, though.
It would. I guess we could ask ChatGPT. I did ask ChatGPT about compounded GLP-1 as well.
Oh, what did it have to say? I'm curious to know the answer there.
Yeah, it said whether compounded GLP-1 is bad or good depends. Usually when an expert answers, the expert does start with, it depends. I know we've both been told to say, just tell us the nuance. Don't say it depends because then it gets confusing for people. But it does often depend. But it varies regarding the quality of the compounding process, the source of the ingredients, and the specific needs and health conditions of the individual patient. And honestly, I think those 3 things are perfect. Those are the 3 things that we typed up in our answer when we're asked about compounded GLP-1s. The source of the raw ingredient, for example, the biopeptic FDA inspected facilities. That's a great start. That's kind of the gold standard for raw ingredients. Maintain strict third-party testing protocols for both sterility and content. And then this is a sterile compounded medication. You should have a sterile compounding pharmacy.